us today for the California Dental Public Health Office Oral Health webinar on local oral health programs moving forward together. My name is Katie Conklin, and I'm a project policy analyst at UCSF's California Oral Health Technical Assistance Center, also known as COTAC. COTAC is a team of dedicated faculty and staff who provide dental public health resources and support to the work of support the work of the Office of Oral Health and local oral health programs. On behalf of the Office of Oral Health and COTAC, I would like to thank the California State University, Sacramento, Kim Sells, and the Office of Oral Health, Miranda Walker, and the Planning Committee for organizing today's webinar, and for all of you for joining and participating. Next slide. Great. A few housekeeping tips. Today is an interactive webinar. We want to hear from you and have set aside time for questions and answers. So please take a moment to adjust your screen to see the PowerPoint slides and video. Most presenters will have their cameras on. And for those on the phone, the PowerPoint slides and agenda were emailed yesterday. Please use the chat box to send questions. And if we have time, we'll use the raise hand feature. And as a reminder, today is recorded and can be shared with your team at a later date. Next slide. I would like to thank today's presenters from the Office of Oral Health, UCSF, and local oral health programs. Next slide. Today's agenda has two parts. Part 1 on dental guidance and Part 2 on grant-related activities. So we encourage you to take stretch breaks throughout during the Q&A session. Our objectives today are to identify key changes to COVID-19 guidance for dentistry, PPE, and preventive protocol, understand the additional guidance for purchasing COVID-19 supplies, understand the process for reporting oral health activities affected by COVID-19 and budget revisions, and discuss alternate activities in the work plan. Next slide. So it is my privilege to introduce Dr. Kumar, our California State Dental Director, to provide an overview of the COVID-19 pandemic and its impact on dentistry. Thank you, Dr. Kumar.
Thank you, Ms. Conklin. Good morning, everyone. Today, I'm going to give you a little bit of overview of what's happening with COVID pandemic. And then we will discuss some key changes to the dental guidance. Next slide, please. This is a graph showing the status of the pandemic in the US and in the European Union. So the population size is similar. So you can look at the graph, and what it shows is that in the European Union, it peaked and the curve was bent and flattened at a much lower level compared to the US. For some reason in the US, the curve has remained at a higher level, and you can see in recent days that it has been going up. So the number of cases, as you can see, is a lot higher now in the US compared to the, so most of the states started opening in June, and this could be the reason why the cases are trending upward in the US. So in the US, the implementation of stay-home order, mask use, enforcement, and the contract tracing, it has varied from state to state, and within the state, it has been uneven within counties. So in some countries, quarantining is very strict. Once a case is suspected, they are not allowed to stay home, and they are usually in an institutional setting under supervision. So in the US, that kind of quarantine is not possible. That may explain part of the reason why the infection is still spreading in the US. Next slide, please. So how are we doing in California? The cases are progressing. So as of June 29th, you can see here, we had about 216,000 cases, 5,300 new cases. So this is from Friday statistics. So 57% of the cases are in 18 to 49-year-olds, and 56% of the cases are among Latino population. So one good thing is the number of deaths have not changed that much over the months. It's about, the last number I heard yesterday was 33 deaths. And most of the deaths are occurring among those who are 65 plus. It's something like 78% of the deaths are among older population. So there is geographical variation within California, and it is the cases are going up at a much faster rate in some counties, and it has presented reopening challenges. So how it affects dentistry, it remains to be seen. So the next slide shows where we are with respect to openings. So this is a survey conducted by the American Dental Association's Health Policy Institute, and they ask questions of dental practices. And as you can see, when the stay-home order, this is California-specific data. So the CDPH issued stay-home order on March 8th, and you can see by March 23rd, most of the offices started closing. And then May 27th, we released the reopening guidance document. And as of first week of May, as you can see, 74% of the practices were open, but only seeing emergency patients. And June 15th, that week, as you can see, most of 26% or 27% of the offices are open, and the business is as usual, whereas 68.4% of the offices are open, but still seeing lower patient volume. Next slide, please. Okay. So although most of the offices are open, the patient volume is lower. You can see the bottom bar. That's the week of June 15th. So only about 33% of the offices are saving 76% or more of what is typical. So the patient volume is still less. So this has some implications because even though the offices are open, they cannot see a lot of patients. Next slide, please. So CDC has issued 2 updates since we issued our guidance. The latest one was on June 17th, and it has more details about work practices and patient management. And this is the NIOSH hierarchical approach to managing risk. And the most effective approaches are on the top, and as you go towards the bottom, some of these strategies are least effective. And as you can see, not much has changed in eliminating, because I mean, it would be ideal to test patients in a dental setting before treating, but that's not available right now. So we are relying mostly on screening patients to rule out COVID-19. So that is the most effective strategy. And if you think of who's going to do that, most of the dental offices, it will be the secretary will be calling patients. So it's more important to train that person who can screen patients appropriately. And engineering controls, again, administrative controls, not much has changed when it comes to those 2 categories. And PPE, of course, respirators, mask, face shield, eye protection, gloves, and protective clothing. So dental offices are used to bloodborne pathogens, implementing bloodborne pathogen standard using standard precautions. And now they have to include droplet and airborne transmission standards. So some of these measures are not new to dental offices, but now they have to take some extra precautions. Next slide, please. So I thought of sharing with you different types of masks and respirators that dental offices are considering now. So there is still a shortage of these supplies, and many of the questions are focused on whether they can use surgical mask and face shield to perform most of the procedures, and that is not the case. As you can see, the surgical level 3 mask here, it's approved by FDA, but it's very difficult to find out the filtration capacity of some of these masks. And it has to be tied in the back, not the ear loop type mask. This is not recommended for aerosol generating procedures. So the biggest problem is with the fit and with the filtration. And as you can see here, there's a mannequin with a 3D printed frame that is fitted to a surgical mask. This is one of the techniques some companies are marketing. It improves the fit, but it's not been approved by OSHA as a substitute for respiratory protection. So currently the recommended protocol for respiratory protection is an N95 or a higher level of protection. And I'm sure you know that N95 respirators are in short supply. When they're available, mostly they are available in only one size. That presents a lot of problem in fit testing. And recycling is an issue also. And then it's difficult to wear for a long period of time. So there are some masks that improve the comfort, like one here next to it, that's the exhalation valve. And it's not to be used when operating in a sterile field in an operating room, but most dental offices can use this with a face shield or somehow, and covering the valve, but sometimes when you cover the valve, that can increase breathing resistance. So the recommendation is to use a face shield. Then there are alternatives to KN95 masks. These are the N95 masks. These are mostly from China. There are KN95, and there are some issues with the quality of these masks. Some of these masks have not been approved by FDA, and there's a whole list of them. And then there's a company that's marketing this reusable quarter mask. N95 is a half mask, and this is a reusable quarter mask. The nice feature is you can take out the filter and replace it with a new filter. And the fit is much better because the seal uses a jelly-like material. And what I'm hearing from dentists that this is more comfortable to wear. One of the issues with this is that the protection factor is 5 as opposed to 10 with N95. But what I'm hearing is that this is much more comfortable, and this is designed for reuse. And lastly, a PAPR. It's the air purifying respirator. And this is one that is designed for the use in dentistry, because some of the dental offices use loops and lights, and the regular PAPR will not accommodate that. But I believe this one has been designed to accommodate that. And this is lightweight, and also there is no tubing behind, so this is more flexible. But this is expensive. It costs about $1,300, $1,500. Again, even if a dental office wants to purchase it, it's not available in the next 2 to 3 months. The other expensive part with this one is the shield that goes to protect the face and the mouth. According to the manufacturer, it has to be disposed after every patient, but it costs about $6 a piece. So it can be reused and changed at the end of the day. So that is off-label use of with this respirator. So the next slide, please. So Cal OSHA is working on industry-specific guidelines, including dentistry. Hopefully it will be released sometime soon. So it also recommends education and training of dental health care professionals. So a key to the successful implementation of these protection strategies is education and training. So this is where you can help dental offices in disseminating the CDC guidance. So providing education and training on preventing transmission of infectious diseases, including refresher training, and ensuring that all dental health care personnel are educated, trained, and have practiced in the appropriate use of PPE. So with the COVID epidemic, and we are still learning the nature of this epidemic, and the guidance keeps changing from month to month. So it's very important to update dental healthcare personnel with new information. And this is where you can play an important role. Next slide, please. Okay, so we have been working on some protocol for public health settings, especially in schools, WIC, and some of those kinds of settings. And I'm pleased to introduce Ms. Joanna Albo to discuss the new protocol that we are planning to release sometime soon.
Thank you, Dr. Kumar. All right, well, good morning, everybody, and thank you for attending the webinar. I want to welcome you. And for this presentation, Katie Conklin and I want to share some highlights from the CDC guidelines. So next slide, please. So this is important to reduce aerosols generated during preventive procedures. And for this presentation, we also wanted to provide information to assist our local oral health programs in addressing questions from the dental professionals that are providing these preventive procedures in public health settings. It is important that clinicians follow the CDC interim infection prevention and control guidance for dental settings during the pandemic, as well as Cal OSHA safety guidance on coronavirus. Providing preventive dental services should be a primary focus in preventing potential dental emergencies. Because of the unique characteristics of the dental setting, just like Dr. Kumar was saying, there are always considerations to protect against bloodborne pathogens, but now we have this added transmission-based standards to protect against aerosols. So although we cannot eliminate aerosols, employing these interim changes to reduce or minimize aerosols will be really key during this reopening process. So the CDC guidelines for non-aerosol generated procedures ask that we avoid use of dental handpieces, air water syringe, and ultrasonic scalers. And this will really help reduce the amount of aerosols that the clinician would be exposed to. Aerosol generating procedures are not necessary for dental care. Use of four-handed dentistry, something that they call a high volume evacuation suction, so it's the large suction that they use when they do dental care, is recommended. Dental dams to minimize splatter. So these are some of the things that CDC has recommended to reduce aerosols. Next slide, please. Katie was going to introduce our work group that helped to put together the protocols for recommending different procedures for reducing aerosols. Katie?
Great, thank you, Joanna. Working since May, the work group has developed a draft interim protocol to reduce aerosols during preventive dental visits and oral health messages for patient education. So we would like to thank the work group and the leadership of the Office of Oral Health, UCSF, and dental public health reviewers who gave their time and support. And Joanna, would you like to talk about our findings for the protocol and messages on the next slide?
That'd be great. Yeah, next slide, please. So in this work group, what we identified is that education and training would be really important, and that we were going to make a list of some key preventive services that can be done in public health settings that would reduce the amount of aerosols for the clinician. And or changes to certain procedures. So the first one is a prophylaxis, which is basically the dental cleaning. So in dentistry, we kind of shorten this and refer to it as the prophy. So it's your dental cleaning, and this is in the absence of any type of gum disease. And what we're recommending is eliminating the use of the rubber cup. So typically when you get your teeth cleaned, the clinician will scale and then polish the teeth with this rubber cup and pumice. And because of the speed in which that rubber cup spins, it actually produces a lot of aerosols and splatter. So it really puts a lot of things out into the air. And so for the prophylaxis, we were asking that we eliminate the use of an ultrasonic scaler like CDC asked and replace that with hand scaling. And in place of the rubber cup polish, we're asking that you use a toothbrush and floss to remove plaque. And this is important to present to the patient so that they understand that the cleaning may look a little different during this interim, but the reasons why, so is to reduce aerosols. And the second one is dental sealants. And so for dental sealants, they're recommending the use of glass ionomer sealants. And the reason for this is that they're moisture tolerant. So before, when you would place a dental sealant, the tooth had to be very dry that you could see how dry it was. And in this case, the tooth can be cleaned with a toothbrush to remove any debris and dried off with a cotton tip and gauze instead of the air water. So again, we're trying to eliminate some of these things that CDC recommended elimination of. So the air water syringe. So typically they'd use the air of that to really, really dry and desiccate the tooth. And so in this case, we're using gauze and cotton tip and then glass ionomer sealants, which are really preferable in this setting because like I said, they're moisture tolerant, but the best feature of the glass ionomer sealant is that they can release fluoride long after they're applied. So they keep protecting the teeth. And then fluoride varnish, which can be applied to the tooth without providing a cleaning and in various settings. And silver diamine fluoride. So I'm not sure with this group how familiar you might be with silver diamine fluoride, but this is a procedure that's non-invasive. This is a liquid that can be placed and will produce very minimal aerosols. It's used in place temporarily in place of putting in restorations. So it can arrest decay, which means it can stop the decay process, but it requires more than one treatment. And then it should be followed up with having a restorative restoration placed as soon as possible. But the nice thing about silver diamine fluoride is that it can arrest the decay, stop the decay process, which is important because if our patients are having trouble getting into the dental office, the longer they wait, the greater the decay process continues, which could lead to an infection like an abscess. So this can help prevent those infections. But I just want you to understand that it should be followed up with a restoration at some point. Next slide, please. And then think about messaging for the patients. So again, we are explaining to them why the visits may look a little bit different, why we're implementing different procedures, but that we're just reducing aerosols during this time, and that it's just a safety measure for the offices or out in the public health setting. And we're just doing this to prevent illness and assure safety of everybody that's involved. Next slide, please. And then Katie was going to go over the protocol and the flow chart that she developed and the team.
Yeah. And so Joanna went over the non-aerosol generating procedures, and we decided to put that into a flow chart. So our findings for the protocol messages are compiled into a one-page handout to communicate the changes in the procedures to reduce aerosols encourage healthy habits, including daily flossing and brushing twice a day for 2 minutes with fluoride toothpaste, and also to explain selective polishing and the causes of stain, especially how tobacco stain can be a teachable moment to cancel and refer patients to the California Smokers Hotline. Next slide. So these are a few policy papers and studies that guided the work group. And these will be available in the presentation following. And then Joanna, what is our plan going forward?
Yes, so our partnering organizations are reviewing the protocol and what the work group developed, and then as soon as they approve, we're going to be distributing this.
Great, wonderful. Thank you so much. So it's time for our first Q&A. So let's go ahead and look at the chat box. I think everyone's kind of waking up this morning.
Yeah.
But we had a great overview from Dr. Kumar on dentistry and how it's been impacted by COVID-19, and followed by some new recommendations for preventive dentistry. All right, so it looks like we have a question for Jan Resler. And then Dr. Kumar, do you want to bring your camera back on so we can see you? Great, there you are. I think you're going to be the guest of honor here.
Yes.
Who are the partnering organizations? Oh, I think that was, yeah, let's see. Sorry, Jan, can you explain that a little more? Who are the partnering organizations?
I think it's in reference to that our last slide was saying that we were waiting to hear back from feedback from our partnering organizations, and Jan, you know, it's a number of people from CDA and CDHA, as well as some other people that we chose to kind of pilot this, you know, for readability, for understandability. So there's some from our local oral health programs, as well as some of the key dental organizations in the state. So we were just trying to get some feedback from a variety of organizations for reviewing the protocol. Yeah, exactly.
All right, other questions? Any questions on dental guidance? We have Dr. Kumar here. Joanna. Don't be shy. I know you can get up and you can stretch. Okay, so we have Caitlin Pierce from San Joaquin. Will the flowchart be available with the protocols? Yes, it will be. So it's the protocols, it's a 4-page document, and the flowchart is one of the pages that can be easily printed and put into an operatory or taken into a public health setting.
Maybe we should clarify that this is intended for public health settings, number one. Number two, this is something that they should consider, because if they are interested in using a rubber cup prophy, they can always use, and they have to follow the respiratory protection program when they use the rubber cup prophy, as well as with this one, but this will reduce less aerosol compared to the use of rubber cup prophy.
And then we have a question from Laura McEwen from Humboldt County. Will you come out with guidance about toothbrushing in the classroom? This was a big part of our programs, also part of Head Start.
Not yet. We want to wait and see what the federal agencies will do with respect to the toothbrushing program. It's slightly different. So a toothbrushing program, when everyone is brushing, that is different from when you are providing dental care on an individual level in a closed setting. So right now, we are still waiting for guidance from some of the federal agencies on toothbrushing in classrooms and in Head Start and other settings.
And this is a question from Mary Ellen. At what point will people be able to resume procedures that produce aerosols? And there's a second part to that. So do you want to do the first part first?
Yes. So that is allowed right now. You know, dental offices can provide aerosol generating procedures The only difference is when they are providing aerosol generating procedures, they have to use this added precaution, transmission-based precautions. That requires, N95 type of respirators or a higher level of protection. And so in order to use those, they have to make sure that there is adequate supply of properly fitted respirators. That's the only restriction right now.
Great. And then the second part of the question is, does toothbrushing produce aerosols in the classroom?
Everything produces aerosol, including talking, speaking. So toothbrushing in that respect is no different. It may produce a little bit more, but a lot less than singing, for example. You may have heard about transmission of COVID in a church setting when they were singing in a, by a choir in Washington. So there was, I think, 46 out of 70 or so people developed COVID because they were all participating in a choir. So this virus is easily transmitted. So that's the reason why we are urging everybody to take extra precautions.
Next question from Cynthia Pledger. Is the flowchart intended for use by the dental provider or to be given to the client?
By the provider. It is for the provider. The most important thing is to communicate this change to parents, because some may think that the only way to get cleaning done is through the rubber cup prophy. And so it is important to explain to them that during this period of COVID epidemic, we are planning to use toothbrushing to clean teeth and apply sealant and fluoride varnish.
And then Prasanti Patel, will you be discussing the allowance and best practices for COA? And that will be part of part 2.
So this is intended for public health settings. So that's so we are working with the Medicaid program to make necessary changes to allow for billing for these procedures.
Okay, and then a question from Prima. Will there be messaging handouts created by the state or Smile California promoting brushing twice a day for 2 minutes and flossing?
There should be some materials on the California, Smile California website. So, I have to emphasize this. Smile California website was created to increase dental visit rates. So as part of that, we have included some materials about promoting healthy habits. So this is where local oral health programs should be incorporating these messages.
And then a follow-up to that question, they were asking if these materials are in English and in Spanish. And I can add, we've been working with the American Dental Association to translate a flyer, one-page flyer for adults and a separate one for children from English to Spanish. So we're almost done with those revisions and they'll be available soon on the ADA website. Another question, for purchasing PPE, is there a company recommended to buy from?
No, we cannot endorse, we cannot promote specific companies. We can give, we can find a list of, we are trying to find a list of companies, but we don't want to endorse a product.
A question from Dana Krinsky. When talking about dental care in the school, SDF is even more controversial than fluoride varnish. Are you recommending moving forward with this? And will there be a guidance? And then there's a second part. So if you want to do the first part.
We're still wondering whether any of these procedures can be provided in a dental, in a school setting, because I don't think schools will reopen soon. So we are not even, we are not there yet. And SDF is even more than F. It's controversial only for the reason that it stains decay. So that's the only controversy. It has to be used carefully, more carefully than fluoride varnish. So I don't know what other controversies are there when it comes to silver diamine fluoride.
The second part of that question is also on preventive procedures. Also, I have been informed, not sure, that glass ionomers are considerably more expensive than sealants. Is this also recommended in the school setting?
So, yes, glass ionomers are more expensive, but they are easier to use, especially in public health settings. As far as the outcome is concerned, if we look at retention rate, the retention of glass ionomer cement is less compared to resin-based sealants. But when it comes to caries prevention, they are equivalent because some of these materials are hard to detect in pits and fissures. That may be one explanation for that. And is this also recommended in school setting? Yes, especially now, because it's a lot easier to use compared to the resin-based sealants.
A question from Johnny Augustin. Prior to pandemic, we have public health staff apply fluoride varnish in a field setting, like a health fair or school. Is that allowable once the restrictions lift? Or will it need to be done in the provider's office?
At this time, I say it needs to be done in a provider's office.
Alicia Roos, can we distribute this information to our local dental providers and to our community to bring awareness?
This is intended for public health settings. So I don't know if local providers are going out to the community and providing these sealants and prophy and things like that. To me, it's appropriate to give it to those providers.
And then Naomi Underwood has a question. As far as PPE, are the N95s that have temporary approval, FDA, NIOSH recommended? These are the type typically available through Mohawks.
Yes, for during this pandemic, yes.
Okay. We still have time for questions. We have about another 5 minutes for the Q&A.
You may have skipped one question, Katie. The ADA 2x2 messaging is only in English as far as I can find.
Yes, we're working on a translation and that will be available soon. I think we're in our last round of revisions. And that'll be available on the ADA website. We have a new question from Jerome. When schools reopen, is applying glass ionomer sealants, varnish, and silver diamine fluoride require direct supervision by a dentist at a public health setting?
No, not at all. Actually, glass ionomer sealants have been available for a long time. Actually, in some in European countries and in developing countries, glass ionomer is more popular than resin-based sealants. And silver diamine fluoride require direct supervision? No. Silver diamine fluoride is nothing but fluoride, so it can be used as a topical fluoride. The only request is the consent form has to be changed because it has a tendency to stain cavities. So it needs to be explained before it is used to parents, explain the staining part.
And that answers our next statement that from Dr. Silverstein that SDF can turn the teeth black.
No, that is wrong. It turns cavities into black. It stains cavities, not the enamel. I don't know where Dr. Steven Silverstein heard this. I'd like to learn more from him about how silver diamine fluoride can stain enamel.
So we have a question from Robin Cox. We are still not allowed to use Prop 56 funds for the placement of varnish or sealants, correct? Or did this change on an interim basis due to COVID-19?
So, Joanna, you want to explain?
Sure.
So these are, here is the reason behind making this policy. Every child should be insured in California. So we have put a lot of effort. Advocates have, used their advocacy power to make sure that insurance coverage is available to every child in California. So public health gets 2 to 3% of all healthcare dollars. So we spend now probably around $4 trillion. We get 2 to 3% of that. And the reason why that we are spending so much money on healthcare is because we are trying universal health insurance coverage. And especially when it comes to children, every child is covered, and they should have a provider who can provide these services. So this is not the role of public health departments, especially using public health dollars, and those are so precious for providing clinical preventive services. So what we are encouraging is to partner with providers who can place varnish and sealants and bill for those services and not use our precious stuff. In order to facilitate that, local health departments can purchase equipment and also materials initially so that these providers can get started. So that's the basis for making our policy regarding the use of Prop 56 funds.
And then Dr. Kumar, if we have time for one more question, we have Dana Krinsky. I have a practitioner who uses SDF and then puts a glass ionomer on top to reduce the visual unappeal.
Great idea.
That's very typical. And then Katie, real quick, there was one other question that I received, and it was about this idea of the prophylaxis with the toothbrush. And they were concerned that there was some description in some articles about it being called a toothbrush prophylaxis, and that we were kind of renaming the prophylaxis. So I just wanted to try to explain that, that's not the purpose for using the toothbrush. We're not changing the prophylaxis in any way. So with a prophy, the clinician has to remove all the hard and soft deposits. So we're talking about plaque and calculus that builds up on the teeth that harbor bacteria that cause disease. So as long as we're removing plaque and calculus, that's the definition of a prophylaxis. Now, in the past, a rubber cup was usually used to polish and remove plaque. And all we're saying is that produces more aerosols and splatter than the toothbrush. So we're asking that, use the toothbrush in some of these public health settings with floss to remove the plaque, and then hand scaling. So we're not saying that a prophylaxis only involves a toothbrush. It's any aid that would help remove plaque and calculus that we're not producing aerosols. So, no ultrasonic, we're doing hand scaling. There's other aids that clinicians have, like rubber tip and other things that they can use, little proxy brushes, whatever it might be, that's not producing an aerosol that you can remove plaque. And so we're not renaming that prophylaxis or changing it in any way. We're just trying to reduce the aerosols. And typically in the dental profession, if you read the literature, polishing with a rubber cup, they say to do that selectively. So typically you might do that if there's stain. Stain's harder to remove with stain caused by things like coffee and tobacco that builds up on top of the tooth surface, not embedded within it. The rubber cup with the pumice will polish that off. But they want to do that selectively only in areas where the stain is visible, because stain in itself, if it's not embedded in calculus, doesn't have bacteria. So there's no therapeutic value in removing that stain in and of itself. So that means there's no real reason to use a rubber cup and pumice because it actually removes some of the fluoride-rich layer of the enamel. So over time, you know, you could be removing layers of the enamel, so you're actually causing damage. So in this way, we're just saying if you're using a toothbrush and flosser, that's a great moment, a teaching moment for the patient, because you're not only allowing that ability to show them that this is how you remove plaque at home, brushing and flossing, and that we shouldn't really be using the rubber cup polish every time, just selectively. So there's a lot of reasons for it, but particularly in this public health setting, this was one of the recommendations to reduce and minimize aerosols. Not that we can eliminate them, but we're just trying to reduce them. Do you want to add anything to that, Dr. Kumar?
Now, if somebody uses a toothbrush just like a Profi cup so vigorously, they can generate, you know, droplets. So that, you know, you have to use it carefully, gently, wear PPE, and that's the way to do it, in my opinion.
All right, well, thank you. So that's the close of our first Q&A session. We'll go ahead and stop your video, Dr. Kumar, and Joanna, if you want to stay on. But please keep writing your questions in the chat box for our next Q&A in about 30 minutes. And now that we've had an overview of the COVID-19 pandemic and its impact on dentistry, I would like to move forward to part 2 of the agenda, to grant-related activities. Next slide. And welcome back, Ms. Joanna Albo, to provide an overview of Office of Oral Health guidance on school activities and purchasing and the 5th progress report instructions. Thank you, Joanna.
Thanks, Katie. Okay, next slide, please. So we thought it would be nice to review the guidance that was sent out on April 30th regarding a few of the activities that were recommended. And some of them may have slightly changed just because that was early on the 30th, but the Office of Oral Health still recommends the following activities that would be acceptable to work on until schools reopen, which again, you know, we don't know when that might be exactly. So we recommend that you coordinate with schools to identify children that may need toothbrush kits and other dental information. Work with schools to provide toothbrushing kits that could be distributed with back-to-school packets, meal pickups, homework pickup, mailed to school or back-to-school roundups, since those will be coming up. You should include something that will help promote the daily brushing, so 2 times a day with fluoride toothpaste for 2 minutes. And that could be things like a chart or a calendar or some other tracking method. And we provided a resource here that has a brushing calendar. And again, it's just an example. Everybody's been really creative, and hopefully we can share some of the resources that the different counties have come up with. Next slide, please. So with the toothbrush kits, the kits should include toothbrushes, floss, fluoride toothpaste, messages about the importance of maintaining oral health and daily oral hygiene. Oral hygiene instructions are always important. Different toothbrushing activities, for instance, playing a song or using toothbrush apps have been really popular, and promoting starting this habit of daily brushing. We recommend that you could include COVID-19 information, especially describing dental emergencies and what they are and what to do and what resources are available, like Smile California and the safety net clinics that are in their area. And then we have a few more resources that we can share, including some information about brush book and bed materials, and some curriculum that you can use maybe with distance learning. And again, we're going to share all of these slides so that you'll have easy access to these links. Next slide, please. To continue with the April 30th guidance, so communicate regularly with the schools that you have established relationships, to keep those relationships. Offer to participate in distance learning, like we said, inform students about oral health and toothbrushing and nutrition. You can plan with schools once teachers and administrators are back, if they are, about upcoming school year activities and different events maybe even arrange for on-site school visits to provide oral health education, and setting up for the kindergarten oral health assessments, and distributing toothbrush and toothpaste kits like we talked about at those opportunities. Provide regular contact regarding oral health messaging, be a resource for these teachers and students and parents and administrators, and be creative with approaches and staying in contact. In some ways, we've had some feedback to say that because schools are so unsure of what the future may hold, they may feel pressure from the outside of starting these programs and what they would be like and not having answers, but staying in contact and trying to be that resource for them. Like, how can we help? These are the resources that we have, will be very welcome. So reach out to schools maybe who previously were not receptive, because they may be looking for those types of resources to support their students during this time. Next slide, please. You can develop your local oral health program webpage if it already hasn't been developed, and post guidance for dental related COVID information. You can identify and provide resources for your county regarding the importance of maintaining oral health, especially during this crisis. You could provide a list of dental providers, safety net clinics that are open, inform about how to obtain Medi-Cal dental coverage, provide information about obtaining COVID testing, and any type of information or alerts and upcoming guidance. That would be wonderful. Next slide. So we also sent out some guidance on June 4th, and this was in relationship to some purchasing to support dental providers. So these would be dental providers that are serving our underserved, so our target communities. And those purchasing guidelines included N95 fit testing, and several of the local oral health programs have had some really successful events helping their local dentists with fit testing. Personal protective equipment materials, so things like the N95 respirators, face shields, which are important, goggles, surgical masks, and other infection control equipment. It could be like sanitation supplies, patient face masks. So when they're coming from the outside, like the parking lot, and to the office, they're asking that they wear face masks until they're actually brought into the clinician's room, into the operatory. There are touchless thermometers, and any materials or brochures, flyers, banners, handouts that are related to COVID-19, and all of the oral health messaging that we just talked about would be appropriate. Next slide, please. And finally, ensuring dental providers are receiving all the appropriate COVID-19 guidance and resources. Like we said, are really important from CDC, CDPH, and the California Dental Association. We should also please notify the Office of Oral Health when dental practices in your community start to reopen, or if the local health officer sends out any new guidance for healthcare professionals, which includes dentists and dental health professionals, about COVID-19. So remember that we have national, state, and then local guidance. So for each county, the local health officer may have a little stricter guidance. And so that's where this is coming from, about just notifying us what's going on in your local area. Next slide, please. So we've been trying to come up with a few other activities to suggest. And one of them was coordinating dental screenings, such as drive-through dental screenings that can coincide potentially with COVID testing, or they could be kindergarten oral health assessment only drive-through screenings. But the idea of the drive-through COVID testing was modeled after the Asian Health Services in Alameda County with Dr. Lay. So she knew that they were doing drive-through COVID testing. And she thought, why can't we go ahead and do the dental screenings for our patients as well? And that was really successful. We also would love for that if you would promote kindergarten oral health assessments to parents and teachers, and establish a dental referral list by conducting surveys of dental providers in your area that are willing to provide kindergarten oral health assessments. And next slide. Okay, so lastly, with the 5th progress report instructions, will you go on to the next slide? So the most appropriate objectives for reporting COVID-related activities would be objectives 6, 7, 10, and 11. But we would ask that you would exercise your professional judgment in deciding which objective is the most appropriate when you are reporting these activities. Again, activities that may not have been listed, but that you're considering, you can ask your program consultant or grant manager or CC the dental director mailbox. You know, all of these will be considered. We like these innovative ideas, so don't think of this as these are the only suggestions that we have. We love to hear from the counties and what's going on. So you can always ask and we could talk about it. And again, you know, it might be appropriate in a different objective, but these were the ones that made the most sense right now because particularly 6 and 7 were the ones that we're having trouble, right? We're not able to go into the schools just yet. So we're trying to find activities to do in the interim. So what we're asking in the progress reporting instructions is that we add a row at the end of the relevant objective and insert details regarding the COVID activities. Then you can complete each column. So for example, if you chose objective 6 on your progress report template, it ends with 6E2. So you would just add a row following that and insert COVID and then the activities, excuse me, that you started or completed. So next slide, please. So here's an example of what that might look like. Just did a pulled from the progress report, and there's 6.E.2, which is the last row, and then we added 6 COVID. So for example, you could say the activity would be to work with schools to provide toothbrushing kits that could be distributed in these variety of ways. And the outcome measure would be the number of children receiving the toothbrush kits and educational materials. And you can, you know, let us know if that's completed or if you haven't started or if it's in progress. And then just the notes and comments, just like you've been doing. Each one of the local oral health programs have provided really detailed notes and comments in this area, and it's really helpful to us. And this is just an example. So you would let us know how many kids received the toothbrush kits, what it contained, and any additional materials that you may have shared. Next slide, please. And then most importantly, please always send a separate document of your summary of the successes, challenges, lessons learned, and any technical assistance that you may request. This is really important because it helps us to document any challenges, especially during the COVID-19 time, and to identify successful strategies. Again, you guys have been very innovative with some activities. So successful strategies to address the challenges, such as providing the fit testing or providing the toothbrush kits. So that would be wonderful. We expect that for each progress report and we appreciate it. Next slide, please. Yes, so then that will be the end of that section, and we're going to send out an actual copy of the 5th progress report guidance and instructions. And you know, towards the end here, we'll have a moment for some questions, so you can let me know if you have any questions. So now I'm going to turn this over to Kimberly Steele and Rosanna Jackson from the Office of Oral Health, and they're going to go over budget guidance. Thank you.
Great. Thank you, Joanna. And just a reminder to keep writing your questions in the chat box for the upcoming Q&A in a few minutes.
Okay, I'm on. Can you see me?
You do great.
Okay, great. Well, thank you again, all of you, for attending today. I know a lot of you want to know how this affects your budget. Can we go to the next slide? Thank you. So I'm going to cover the first part, the first 2 bullets, and then Rosanna will join us for the last one. So LOHPs may use up to 10% of their approved budget. This will include any remaining 1920 budget that you'll move to your 2021 budget. That's with the understanding that your program must maintain adequate budget to complete the activities in the work plan. Okay, and then the second bullet there is funds may not be used for redirected staff. However, funding can be used for activities that directly benefit or support the current scope of work and the populations the funding is intended to serve. Here's some examples. So, training on updated guidance for the COVID-19 in dentistry, facilitating N95 fit testing training, providing appropriate PPE to dental providers, under the current emergency conditions, to increase access to preventative services for underserved populations. In addition, funds may be used for providing education and oral health kits, as Joanna was mentioning, to promote healthy behavior. Also, equipment and supplies that might be needed to accommodate changes to school-based or your school-length preventative services, and then also community clinical linkages to support integration between medical and dental activities. If you have questions about this, and I'm sure some of you will, you can contact your grant manager. They give you further information or guidance related to the funds and how you can spend these. You can also email the dental director. I'm sure all of you know that, but it's dental director, one word, at cdph.ca.gov. And that is monitored all the time. So we'll certainly get back to you. So on the next, for your budget revisions are due September 30th, and they should include any proposed purchasing that you have. You'll send those, as we regularly ask, to the dental director email box. That allows us to track them and then to make sure they get to the appropriate person. As a reminder, for this budget revision, you will finalize your fourth quarter invoice for the current year. And then what you'll do is you'll revise your 1920 budget to show your actual expenditures. The remaining
Kimberly, you accidentally are on mute.
Sorry about that. Of course, a call comes in when I'm in the middle of a presentation. Haven't had one since now. Seems to happen to me. So sorry about that. I'll go back just a moment. So I was talking about the budget revision, and I'll go over it again to explain that you do need to finalize your fourth quarter invoice, and you'll revise your 1920 budget to show your actual expenditures, and then the remaining 1920 will move into your 2021 budget and be reallocated appropriately. So in the 2021 budget, LOHPs can add a line item under other and identify it as COVID-19 related. And yeah, just under that other category, you can just include an added line. Just identify it that way, and then any proposed purchases or other changes to the budget must include detailed justification, and that should show any cost per item and its intended purpose. That's all I have at the moment. I'm going to hand this on over to Rosanna.
Good morning, everyone. This is Rosanna, and it's great to be with you today. And I'm going to cut to the chase with the budget because I'm sure you're anxious to know. The governor signed the budget yesterday, and it had included a $3.6 million reduction to the Office of Oral Health Prop 56 dental account. However, we are able to adjust the budget and hold back on some other procurements we are planning so that we can leave the local oral health program budgets as is, and they will not be reduced. And further, we are still allowing you to move forward your unspent funds, with the exception of the $17-18 because those have already expired, as those were appropriated under a different mechanism. So there is one caveat, however, that after July, when the budget income taxes are evaluated, as well as Prop 56 revenues, they may come back and revise the budget. So we aren't anticipating any additional reductions, but in this time, everything is uncertain. So we are committed to maintaining local oral health programs and carrying your momentum forward. Also, as a result of the reductions, we are not going to be able to go forward with the RFP for older adults that we are planning. One of the other areas is the children's dental disease prevention equipment. That's temporarily on hold, but not as much as the budget, but because we're waiting for CDC guidance on school-based, school-linked programs. And once we have that, we're planning to move forward. It may be a different amount, but we still are hoping to move that out. One of the other aspects of this impact of the budget reductions is that we are also going to be experiencing some furlough days, about 2 a month. And also we are having staff that are being reassigned to help with the COVID-19 contact tracing and other areas, as well as our whole department is reassigning staff from accounting, the contracts management unit, so things may be moving a little bit slower. The other news is that our program directors meeting will probably more than likely be a virtual meeting, such as we did for our advisory committee and National Oral Health Conference. Unfortunately, our contract with CSUS, as a result of COVID, was not allowed to move forward at this time. We're hoping that as the budget is better known, that the contracts won't be suspended and that we can come back with CSUS, as they are our meeting logistics contractors. And we've really appreciated all the work they have done with us. It's always been exceptional, and so hopefully we will be able to have a face-to-face meeting in the 2021, but that may still change as we don't know what COVID will be doing. The other impact is that with the COVID crisis and all that is happening with our contracts, that our UCSF budget, we are still waiting to see if the contract is executed, but we may have a gap in services if it isn't executed by the end of today. And we just ask for your patience and hope that we'll be back in talk with UCSF if it isn't signed today. But as you can imagine, UCSF is still our training and technical assistance contractor, and we're hoping that we won't have a significant gap in services. But the other thing that the good news is on the dental side is the Medi-Cal dental program. The serious reductions that were proposed have been averted for now, and the state budget will be reevaluated in October because part of the budget was developed with the understanding that they might get some federal dollars. So October 15th is their deadline to look and see if those federal dollars are released. So this may have an impact on everybody. So stay tuned for that. And we plan to keep you posted on any significant changes. But for now, we're hopeful that we won't have to experience any further reductions. Thank you. Katie, are we going to move in?
I was on mute. Sorry. I was just saying, Rosanna, thank you for your update on the budget, and Kimberly for the progress reports. So if you guys can stay on, we're going to look at the chat box for questions. And as a reminder, we welcome stretch breaks. We know we're about over an hour into this. Yeah, thank you. Next slide there. So we're going to start from the beginning. We've had a lot of questions that came in. And then Joanna, if you could also come back, and Kimberly, if you can turn on your cameras. And I'll turn on mine as well. Okay, hi. Okay, just going back up to the top here. So our first question that came in was from Dr. Pendekar, and they were providing other examples that are happening in counties. So San Mateo County Local Oral Health Program will be providing virtual oral health education and instruction for summer schools called the Big Lift Program, for all the school districts that are offering the program this summer. Great. And then Caitlin Pierce in San Joaquin County had a question. Can anyone share what they are doing for distance learning for schools? So I think that's going to be in the chat box. And then we also have some examples coming up in a bit. Jennifer Frechetta, can schools opt out doing AB 1433? Rosanna, do you want to take that question?
Right now, we're not planning that as an opt-out because there are other ways to promote the kindergarten oral health screening, at least by doing a school linked approach, which we are seeing in different settings. Dr. Lay, and that part will be reviewed in a little bit, has a unique and innovative approach as far as doing drive-through screenings. There's been other ways to do school link, but we're waiting to hear back. And also, it also depends on whether or not schools for this school year are actually going to have students on site. So it's variable, but we don't want to say that you can opt out at this time because it is one of our major interventions.
Thank you, Rosanna. And then we had a question about if any of the counties could share about fit testing for N95 masks. And we have 2 counties that we know of that are doing a great job with fit testing and training. And the first one is Humboldt County with Laura Ewan. So I'm going to see if she can turn on her video, and then we can unmute her. Great, there you are, Laura. Thank you.
Hi, good morning, everyone. Thank you. I'm really honored and kind of surprised to present, but we were actually our dental hygiene professionals in our community were really wanting this, and it aligned really well with what Dr. Kumar had promoted as well. And we were able to find a industrial hygiene company that had the knowledge and capacity to provide these. And we developed a very simple contract. Special thanks to my staff to really expedite that. And we were able to set it up so every dental professional from dental assistant all the way up to dentist could have a free fit testing. And we actually are, for those that have already gone through this company that had it prior to our contract, we are reimbursing them for their cost. So we're really excited about this. It looks like it's a very positive and useful thing, especially for smaller offices. Some of the larger offices that are aligned with a large medical office often have their own fit testing professionals on staff, but we're really pleased, and it just happened about 2 weeks ago. So I'm going to check in shortly and see how the uptake is. Thank you.
That's great, Laura. Thank you for all that work that you've done. It's very exciting. And Katie, you know, I'd like to recognize Amador County because, you know, they really pioneered this idea. Anna came up with this idea, proposed it, and everybody was saying, oh, so that's one of the examples of these innovative ideas that we were talking about. So thank you, Anna. And I think she's available to describe what she did and how she came up with this idea if you want to try to connect with her.
Yeah, so we have Anna right here. Anna, I'm going to go ahead and unmute you if you can share a little bit. Anna, did that work? Okay, we might be able to hear from Anna in just a little bit.
Okay.
Let's go ahead and answer a few more questions. I'm going to go back up here.
Katie, can I go back to the opt-out question for AB 1433?
Yes, please.
Because I just saw the question in the chat box, and the question wasn't can LOHPs opt out, but can schools? And it's always been up to the school district to implement AB 1433. We are trying to encourage them as much as possible, which is why it is a big intervention for our LOHPs. But a lot of times it may be understanding the importance of why this intervention is critical to the success of a student in school. So part of it is messaging with the schools. There's been a lot of misinformation with them as well. So anything you can do to encourage and educate schools why this is so important to them and will actually benefit them would be a good alternative. If you can't do schools in the initial period, is to try to work with school administrators or to find a champion at the school district or in the school to help promote them taking on the kindergarten screenings, and also to say that you're there to support their efforts. So thank you.
Thank you, Rosanna, for the clarification. And then Alicia Sanders has a question, and now we're going to switch more to budget and scope of work. What does up to 10% of approved budget, does that mean we have to get a budget revision if it exceeds 10% of the budget category?
So this is Kimberly. I can answer that. So the 10% is going to be your remaining 1920 added to your 2021 budget. So a max of 10% of that entire budget can be distributed throughout, you know, the budget to include some of these things we've talked about. That answers it.
Okay.
If you need more clarification, you can always reach out to Kimberly.
Yes, absolutely. Yeah. So yeah, I meant to actually add that into it. So some of you know me, others not, but you can always reach me. It's kimberly.steele@cdph.ca.gov. You know, our staff is working, you know, telecommuting like a lot of you, but I'm here and available to you.
Thanks.
And then is there a way that this could be listed out and sent to the local oral health programs?
Sure, we could look at that. Yeah. Yeah, we were looking at sending out some, just a reminder that this is coming up, but we can certainly add something to that. So we'll work on getting that out within the next, hopefully within the next week.
That'd be great. Yeah, it's a lot of valuable information. I know people are taking notes. And
I just saw something, somebody's still confused on the 10%. So the 10% is your total, it's 10% of your total combined budget. So your remaining 1920 that has not been expended, and then your new budget, which you're going to be revising to add in the remaining funds, it's going to be a 10% of that total. And again, you can reach out to me directly. We can certainly walk through and talk about your particular circumstances in your budget.
And would it be okay if you put your email into the chat box?
Sure, I can do that.
Yeah. And then with all the talk on the budget, there's a question on, is there a new budget template that's been developed?
No, there has not. You know, we were working on that, and you know, we got challenged with capacity. You know, we're still hiring staff. Then some of the staff we do have that's experienced has been redirected. So no, we haven't. We don't have a new template at this time. So you'll continue to use the one you have.
Another question on the budget guidance. Does the budget guidance mean LOHPs can be allocated a percentage of full-time FTE working on COVID if any of the activities aligned with the updated guidance activities? Is that correct?
Rosanna, let me let you jump in on that one.
Okay, if I understand this correctly, if the staff FTE is mainly just working on COVID redirection, like contact tracing or any of that, that percent of FTE cannot be applied to Prop 56 funding. But if the percent FTE is working on any of these alternative activities that we've discussed, such as the fit testing training, working with providers to get their offices up and running, following the guidance, doing some integration with medical and dental, then that is correct.
Let me expand on this one, okay? You have to guard your oral health dollars. These dollars didn't come easy. Many advocates have spent years advocating for oral health money. So if we end up spending all our money on contact tracing, then somebody will ask us questions 2 years from now, how did you spend your money? And we have to explain to them. So I would say, don't put us in this uncomfortable position of saying we used all our oral health dollars for non-oral health purposes when dental offices are struggling to keep their office open and they're looking for guidance how to manage dental patients during this time of COVID epidemic. So I want to emphasize that these dollars are not easy to come by. And as you saw, we are already taking a $3.6 million cut in our budget. So you have to fight for these oral health dollars for oral health.
And our next question is from Rita Chen. Does the work plan fifth progress reports have to be updated and approved before local oral health programs submit budget revisions?
That is a good question. We are going to want to look at that. So that should be your justification, though, in the budget itself should, I would think, mirror what you're identifying on your progress report. So we would have that information and be able to make a decision on the budget. I don't think it should hold it up. If anybody else wants to jump in, fine. But I'm thinking you're going to have the budget revision. You're going to, in the justification, you're going to explain how you're going to be spending this 10% if that's what you choose to do. And then that should correspond with the progress report and that added activity. So it should all combine, and we should be able to approve the budget without it, I'm thinking.
Mm-hmm. Yeah, I agree. I was trying to kind of understand what she was saying, and sometimes we've done some work plan revisions. But in this case, these activities are just suggestions in the interim when we've had the suspension of school-based activities. So at this point, we don't really want to change the work plan in any way. We're just offering different activities while the schools are suspended. Those school-based activities are suspended. So yeah, I agree with you, Kimberly. Thank you.
And you may have already answered this question, but when is the next progress report due?
It is due July, the end of July. I can't remember if it's the 30th or 31st. How many days are in July?
It's the 31st.
31st. Okay.
So coming up. And then Julie Williamson has a question. Can we use year 4 funds for purchasing the COVID allowable items, or does it matter which year the funds come from?
It's going to be a combined. It's going to be whatever's remaining, and then your 2020, and then it's going to be a 10% of that total is what we're going to be looking for, not to exceed.
And then Johnny Augustin has a question. Any recommendations for local oral health programs having difficulty meeting Office of Oral Health objectives because of being redirected to COVID activities? I am the program coordinator, but I have been contact tracing since April.
You should contact your program consultant and have a discussion on that.
We had a question on fit testing, if we want to change gears really quick. Back to fit testing. In order to have fit testing brought to our county, we need 5 people signed up, and we only have 4 dental providers, including our dental hygienist in the county. Can we allow other non-dental providers to join so we can reach the minimum number?
Again, I would say talk to your program manager, contract manager.
We had questions. I'm just going through the chat box from when they came in, and I think, Kimberly, you cleared up a lot of the confusion that people had with the 10%, but you've given your email address, so that's provided.
Yeah.
And then here's a question from Tara Krim. Any chance the budget revisions will be approved earlier if submitted earlier? Just thinking if how we can move forward with COVID-19 support to our schools providers before the budget revision is approved.
Sure. We've been able to spread out the workload a little bit more. So I think it's not going to take quite as long, but we do have some new staff working on it. It's going to need some extra support from me and some of the other staff. So if you are challenged to move forward without an approval, please go ahead and reach out to your contract manager or the dental director email, or even myself, and say, hey, I need to have this in order for us to invoice or some other purpose like that, or to actually do the purchasing, which sometimes I know it needs to be approved. And then what we can do is we can prioritize in that manner. But we know this is important to everybody. It would be first come, first serve. Otherwise, we get them in, we'll review them as they come in. Did that answer the whole question?
I think she said perfect. Thanks so much, Kimberly. I appreciate the support.
Good.
It looks like we have the county that was looking for another provider for help. A neighboring county is going to help them. So a lot of partnering that's happening here. There is a question. There has been some just changes also with Office of Oral Health and some grant managers being reassigned. So if you have questions, who should the counties reach out to?
So they reach out to me. Oh, go ahead.
Yeah, I guess it depends on what the question is.
Yeah, that's true.
But if it's the easiest would be if you wouldn't mind reaching out to me, Joanna Albo, and I put my email in the chat box and CC the dental director. And then if it happens to be a budget related question or an invoice related question, then I can key in Kimberly and her team. If it's a program related question, then we can help you. So I put my email down in the chat box. So reach out. Please feel free to reach out at any time.
Wonderful. And it looks like we're at 11:30, so it's time to move on to the next section, which is, if we can do next slide, please. Thank you, everyone, for your questions. We are going to have time for more Q&A in the next 20 minutes. So that's coming up soon. So now that we've heard the process for reporting oral health activities affected by COVID-19 and budget revisions, I would like to welcome Ms. Keiko Miyahara from UCSF to provide findings from a survey and alternative activities to the work plan. Thank you, Keiko.
Great, thank you, Katie. Good morning. My name is Keiko Miyahara, and I work at UCSF. Thank you for your time to be on the webinar today. So today I wanted to share a presentation on the results from the self-care survey that was disseminated to the local oral health programs last month. So the reason for this survey was to find out on the collaborative efforts with the local oral health programs in their school districts on the oral health promotion during school closure. So from the survey, we identified that many local oral health programs are already engaged in a lot of oral health activities, in which 87% are providing toothbrush kits and oral health education packets during meal programs. This may include dental sealant and fluoride varnish educational materials, toothbrushing calendar, and other oral health promotional materials. And 26% of the local oral health programs are promoting Rethink Your Drink campaign, the Brush Book Bed program, and tobacco cessation, and 17% are creating toothbrushing videos and sending out digital newsletters. Next slide, please. So many have expressed, due to the impacts of the pandemic, their limited capacity and decrease in staff time. We understand that numerous staff members have been reassigned to COVID-related duties, and many of the respondents expressed the uncertainty of the school programs if and when the schools reopen, and what the landscape will look like then. So as for the long-term plans, the LOHPs are looking into different delivery of oral health promotion if providers are not allowed into schools. So one way is to train the trainer for teachers by providing virtual oral health lessons, and also providing messaging to schools on how to provide oral health support and how to resume the preventative services. Next slide, please. So from the survey, we identified that many of the LOHPs are looking for oral health curricula. COTAC has identified these school-based curricula from several of these resources, and these slides are going to be disseminated after the webinar. And many of these provide great teaching resources, including step-by-step teacher's guide, videos, presentations, and activity kits for the students. And few of these curricula, they come in the Spanish language as well as English. Next slide, please. And lastly, I wanted to highlight and promote Dr. Hong Lei's oral health preventative program. She started this kindergarten screening drive-through program in May as calls came in from the parents. And due to the COVID-19 and the restrictions on dental services, her dental office transformed from inside her clinic to the automobiles of the parents. So this program is a coordinated effort by her 3 staff. Each of these appointments takes about 15 minutes. And during that time, her staff collects the consent forms, screens the child for any oral health issues, applies the fluoride varnish, and gives oral health education right in the comfort of their car. So with the success of this program and an article written on the drive-through program, she has received numerous inquiries from other counties wanting to replicate this model. So we're hoping for this model to expand throughout the state. And now it's my pleasure to introduce Kathy Larson from El Dorado County.
Morning, everyone. It's nice to see everyone and have the ability for you to join us today. I was asked to share a little bit about what we're doing here in El Dorado County, pertinent to the kindergarten oral health assessments, especially in times of COVID. And I think a lot of what we're doing around COVID really is mirroring what we've done in the development of our program since day one. And I think a lot of you have emulated and followed this model. But basically, our number one premise really is about building relationships with various organizations, including our schools, our Head Start organizations, WIC programs, and continuing that model during this time of COVID has been a very big success for us. Sometimes when you're starting out and you're hitting roadblocks in terms of trying to develop relationships, one thing that we've done, because schools have been a little bit more of a challenge for us, is really trying to develop shared values among our partners and leveraging those shared values to get the messaging across. And then mostly in our school programs, we've tried to develop the easy wins, or start with the schools that have other relationships that we have with them, and to develop those kind of relationships, and then leverage those schools that have begun to participate in acquiring other schools that are a little bit harder for us to develop relationships with. And so early on when COVID started and schools began closing, we had schools, some of the principals still operating and functioning and responding to emails. And so I was able to stay in contact with them and try to develop relationships over time in terms of getting them interested in when things start opening up, you know, what the plans are going to be. Also to leverage communications that the schools have with parents to remind them about the importance of brushing and keep them up to date on what their local dental office may or may not be doing or when dental offices started opening up. We also did a lot of work with teachers and parents who would get calls from parents when children had a toothache and to help locate dental offices that were providing emergency services. So these are some of the activities that we've done over the advent of COVID in our community. What we're doing in general around COA screening that we're going to have to modify a little bit during COVID when schools start opening up is we conduct passive screenings in schools with the support of our local dental community. And in that passive screening, we've added an opt-in for fluoride varnish. So if the parents don't return the waiver for the COA screening, we go ahead and screen the child. We also may get the waiver back because the parent has opted in to have fluoride varnish, and we found success with that. We also do classroom education as part of the COA screenings with toothbrush kits. And during the times of COVID, we've been putting toothbrush kits in the school lunches for dissemination in several of our community schools. We also do activity boxes for our classrooms, and that program has been expanding. We do education within the classrooms and in the schools, and then we develop boxes that have brush book bed, books on toothbrushing, activities like blocks and Play-Doh and string that help children learn how to begin flossing with instruction for the teachers. So if the teachers need to have spontaneous activities, they can go to the oral health activity box and find things to do for their classrooms. We also have we're beginning to explore drive-throughs for the core kindergarten oral health screenings so that we can have alternatives to the in-classroom settings during the time of COVID. And so these are some of the general activities that we have conducted and are exploring in normal times and then times of COVID and how we're going to get back in terms of promoting oral health in the classroom. I think one of our more successful activities that we've done this past year are the lunch and learn from teachers. I know a lot of you have reached out to school nurses in trying to get your foot in the door to do either classroom kindergarten oral health assessments or education in the classrooms. And we know a lot of our school nurses have so many mandated activities to do that for them, adding one more activity has become a real challenge for them. And so a lot of programs are looking for ways to get into schools and just haven't found success with school nurses. And so going directly to the principals has been something that's been very successful for us, and offering the principals to do lunch and learns with their teachers around the topic of oral health. And so this helps teachers provide oral health education in the classroom as well, but also helps teachers be more mindful of the impact of dental decay in their students and how it really impacts learning. And so to have a time set aside where we provide lunch for the teachers and have a presentation and discussion for the teachers has really helped increase awareness of oral health among the teacher population, and also promotes oral health in the schools. And in those schools, we've been able to do teacher lunch and learns. We find the schools are much more receptive for us to be able to come in and do COAs or classroom education and just work in partnership with the schools. And so these are a lot of activities that we've implemented in El Dorado County, and we're looking forward to modifying some of these programs in terms of providing more assistance during the times of COVID. And so we'd love to take questions later on in the chat regarding our programs, but at this time, I'd like to introduce and turn it over to Dr. Kumar, who's going to provide more information for you today.
Thank you, Ms. Larson, for that excellent presentation. So during this time of pandemic, we are always thinking about innovation. So any innovative ideas you can put forth, please submit it to us so we can share it. Katie, how are we doing with time?
We're doing good with time. We have about,
okay.
20 minutes left.
So we started with 156 people and I still see 149. So that means we are doing very well. So let me take a few minutes to go over some ideas for the future. So we have built this results-based accountability for performance management in our program. I think I shared this with you before. So we are focusing on preventing cavities. We are measuring it in 3rd grade and in kindergarten children. That's our indicator, that's our goal. And then we have a set of interventions. So these are the 5. And we are promoting community water fluoridation, kindergarten oral health assessment, linkage, dental visit, and oral health literacy. So we are measuring all these things except oral health literacy. We are still trying to figure out how to measure it. Suppose we cannot get into schools, we cannot do COVA. So what are some of the options? So that's what I want to explore. And we'll begin with dental visits. So that is key to preventing dental disease and reducing untreated disease. Next slide, please. Okay. So this is from the CMS, and they released this new oral health initiative, which builds on the old oral health initiative, which started in 2011. So they released it on June 25th. So in 2011, the goal was to increase by 10 percentage point over a period of 5 years. So by 2015, the goal was to have Medicaid program achieve this performance of 52% dental visit rate, preventive dental visit rate. So they've been tracking by state. And as you can see, by 2015, we hadn't, nationally, we hadn't achieved the performance, and we were making a very nice progress. Now we are at 48%. So in California, the preventive dental visit rate was 37.8% in 2014, and then California undertook all these different initiatives, including the Dental Transformation Initiative. And over the past few years, we have made a lot of progress. So the goal was to hit 10 percentage point increase by 2020, and we are heading in that direction. And this is the target of national target of 52%. And then in California, for annual dental visits, some commissions have recommended that we should hit 60%, 65%. So we're heading in that direction. So with all these disruption because of the COVID activities, this will be impacted. So how can we maintain that one? Can you go to the next slide? So compared to reaching children in schools and preschools during this epidemic period, it may be easier to access another population group, And this is a target in our state oral health plan. One of the focus areas, pregnant women and young mothers. So how can you reach this particular population group? So there is a national performance measure, that is the percentage of women who had a preventive dental visit during pregnancy. And there are strategies. We recognize that some pregnant women may not want to go to dentists during this time, especially because they are afraid of contracting COVID. So that's quite understandable, but you should be able to help them maintain good oral health. And by doing that, if they maintain good oral health, then the transmission of bacteria to children will be dramatically reduced. And this is an opportune time to instill healthy habits. And therefore, I think this is a very good alternative if you are not already focused on this particular population. And so there are many strategies, monitoring perinatal oral health status. You should have data on dental visit rate for your county, or at least for your region, if you are a small county. And the other thing is there are opportunities to include some questions about oral health status. And the next thing is about educating and engaging women of reproductive age, prenatal healthcare professionals, and community providers. I think Ms. Larson talked about, partnering with different groups, different advocates in your community, collaborating with them to train their members to refer pregnant women to oral health professionals for dental visits. So these are some of the activities, especially education and training, not only of dental, but also non-dental providers. There is this opportunity during this time. And also to develop dental network capacity. So not all dental offices may be willing to treat pregnant women, especially those who are enrolled in Medicaid. So you have to have a good network. And there are opportunities to work with First Five, MCAH, WIC, home visiting, Black Infant Health, hospitals, FQHCs. So many, many partners to improve the oral health of pregnant women. So this is something you may want to explore during this time. And lastly, I want to bring up this policy. There is an opportunity to work with hospitals to include infant oral health kit as part of discharge planning. So if all hospitals have this policy, which is very similar to, say, car seats. When pregnant, after delivery, when mothers leave with the child, they're supposed to have car seats. And similar to that, they should have infant oral health kits. And that can be reinforced 3 or 6 months later by contacting them again and giving them another supply of kits. So this is something you may want to start exploring with your hospitals and working with their OBGYN department to promote oral health during pregnancy. And there are, the hospitals for prenatal classes where it is a lot easier to include oral health lessons for pregnant women. So I think this is a great opportunity to explore how you can work with this particular population group. So there are a lot of resources. I'm going to skip to the next slide. Okay, so AMCHIP has a toolkit called Preventive Dental Visit Implementation Toolkit. National Maternal and Child Oral Health Resource Center has a lot of resources again. And the Campaign for Dental Health, which is, the host is the American Academy of Pediatrics. They have this whole oral health site. So you can look at some of these resources. And if there is a lot of interest, we can hold a separate webinar on this particular topic. Next slide. Okay, so thank you. So we'll be happy to take questions.
Great, thank you, Dr. Kumar. All right, so if the presenters want to turn on their cameras, and then we have 10 minutes for our last Q&A today. A lot of activity in the chat boxes about curriculums. Today's presentation, along with the agenda, have been posted, so that has links to all the curriculums and resources that have been provided. And the counties are sharing activities that they have going on, so those are available in the chat box. It sounds like there is a grant that's available. It's an initiative with the AAP, Protecting Tiny Teeth, and it provides a $5,000 payment for OB providers who track and educate about oral health to their patients. There's an application that's due mid-July, and Laura McEwen from Humboldt says it's pretty easy. We're getting some requests for, yes, please do offer a webinar on prenatal approaches.
Okay. Oh, Kathy, you have a comment?
Yeah, I just wanted to comment that in terms of pregnant women, we actually work with our local First Five agency. They have a kit that goes out for all new parents where the hospital distributes this kit. And they have up to 5 inserts that can go into this kit locally. And so we coordinate with our First Five agency to be able to insert an oral health information and toothbrush kit for new parents in that.
Excellent.
We have a question from Mary Ellen. Is there a good example of what to include in the infant dental kits? What have other folks done?
Okay, so maybe this can be the topic for the next webinar then. So we can put together some resources and send it. Joanna, what do you think? We
Yeah,
should
I
be
think
able
that's
to, right?
Yeah, that's a good idea.
Mhm. And if you have examples like what Ms. Kathy Larson mentioned, send it to us so we can compile this, all these different activities, and share with you.
It looks like Yuba and Nevada County have some innovative things they've been doing with the library to promote oral health and the kindergarten oral health assessment. So maybe that's another thing that we can compile of what other counties are doing.
Mm-hmm.
And there's also another example from Marin County of what they're doing with schools and activities around the kindergarten oral health assessment.
Okay, so about data. So you should have data on utilization through MIHA. I'll check with Mr. Brendan Darcy, and we should be able to share with you the data on. So something you may want to do. 2 things. One is data on pregnant women, and the second one is dental visit rate among young children. So you should be able to see variation. We'll give you a chart by county. You should look at the variation and see where your county stands, whether you are performing better than state average or underperforming. And when it comes to pregnant women, the last time I looked at it, I think it was San Francisco, Marin, and Sonoma counties. They are performing better than most of the other counties. So we may want to look at what is that these 3 counties are doing in order to improve dental visit rates during pregnancy period. So that may give you some ideas about the interventions that you can undertake in your county, especially those counties that are that have low utilization. Similarly, with young children, we'll give you that that data. Oh, Brendan is on the line, and he says we are getting new data on dental visit among pregnant women by county in the next couple of months. So there's the latest.
And counties are writing in what they're doing for their perinatal health kits. It looks like Sonoma County has an idea where they can send a photo to Joanna, and maybe that can be shared. But they use these kits for home visiting.
Okay. Okay, when publishing data, please keep in mind the 3 cities that city level data. It's difficult to get citywide data. Yes, definitely we will look into it.
And then what do we do with counties that have no prenatal providers, aside from WIC and First 5?
That's a challenge. So first thing I would do is, where do they go for OB care? To the neighboring counties. So maybe that's what you may want to reach out to the neighboring counties and work with them. I didn't know that there is a county in California without prenatal providers. I'll have to go back and check that.
Yeah, it's some of the rural counties. And then we have San Francisco next that says OBs are doing warm handoffs to dental offices.
Great. And I think, if I'm not mistaken, San Francisco had a program specifically, for improving oral health of pregnant women, where they brought in, different providers to exchange ideas.
And there looks to be some interest if dental offices can hand off to OBs. Or OBs can hand off, do a warm handoff to dental offices.
Right. I see there are a couple of counties without prenatal providers. Okay.
Well, thank you, everyone. It looks like we're at time. Thank you to all the presenters for your excellent presentations, and for all the local oral health programs for joining us today. As a reminder, the slides are, they've been attached here, so you can find them in the chat box. And today has been recorded for those not able to attend. So in closing, I'd like to thank Kim Sells from Sacramento University for helping behind the scenes and keeping us going the whole webinar.
Thank you.
Thank you.
Thanks, everybody.
Thank you, Katie, for facilitating. You did a wonderful job.
Thank you. Thank you, everyone, so much. It's been
Thank you
an honor
all.
to work on the project. Thank you.
Thank you.